Good evening to everyone and welcome to today's session. We'll have a review of all the image-based questions. We welcome the online students, Rakesh and many more. So from now onwards, we will have religiously a discussion followed by the test. So on every Thursday 2 to 5:30 afternoon, we will have a test, and on every Sunday 9 to 12:30 and 12:30 to 2 we will have a discussion. Okay, so all of you are also welcome to, you will also be given an activation to the account on both the mobile app and also on the web. But I suggest you to use mobile app to do the test. Still come to the center and take the question paper, but do the test on the app. Most of the students, we are encouraging more and more to do the test on the app, because that will give a lot of big data analytics and a comparative performance analysis, and where you are going wrong and right dynamically it can give mobile app. Now let's make the great beginning. How to identify the structures on the CT MRI is a favorite question of the examiner. So what is being shown to you was basically a putamen, which is being caudate nucleus, which is being labeled as A. So you must know that you have a caudate and there is an internal capsule where the descending fibers of the corticospinal tract pass. Then there is a putamen, you can see, and there is a third ventricle and thalamus. So internal capsule is like a ribbon like a strip. On the side of that, one side medially you have thalamus and the other side you have got putamen. So that's a point of interest. Here you are seeing a hydrocephalus. Where is the obstruction in this hydrocephalus is a very important question. So it is a cerebral aqueduct where you are able to see the obstruction at the cerebral aqueduct will make the both lateral ventricles and the third ventricle to go into enlargement. So accordingly, hydrocephalus is divided into communicating hydrocephalus and non-communicating hydrocephalus. Now 53-year-old complains of a strange feeling in his right hand, and there is a loss of sensation in that dermatome. Typically it is the area which is medial, that is a little finger. So that is the reason it is a area of ulnar nerve is what you have to basically remember. An infant is born to a 24-year-old female and there is a difficulty in the feeding, and there is a shortness of the jaw. So typically shortness of the jaw is the Pyrrhobin syndrome, where there is an underdeveloped mandible, and also it will be associated with the abnormal formation of the malleus. So that is how the Pyrrhobins basically has got a problem in hearing. 26-year-old comes with amenorrhea, and she also notes that her breasts are engorged, galactorrhea, and she is taking antipsychotic drug. You know, most of these antipsychotic drugs, they act on dopamine. Dopamine has an inhibitory effect on the release of prolactin. Prolactin in turn has an effect on LH and FSH. So that is the reason whenever prolactin get affected, FSH get affected, and that leads to development of amenorrhea whenever the prolactin values increase is what you need to remember. So increased prolactin also lead to galactorrhea. Increased prolactin inhibits FSH and prevents ovulation and menstruation. So that is a combination. Now you are seeing an electron microscopic appearance. There is a network of claudins, and there is a limitation for the passage of the molecules and ions between these cells. So what is this electron microscopic cell appearance is basically called as? Typically they are the tight junctions, the occluding tight junctions of the endothelium of the capillary are the ones which are being shown on the electron microscope. One of the favorite questions in NEET PG exam among the people who recall the questions, and purposefully will make the paper sometimes tougher, sometimes easier. That's the purpose of the mock test. And every week we have 2 mock tests, and in the next 12 weeks we have 25 mock tests. Regularly your performance should increase. We give 150 questions image based and 150 non-image based. But actual exam, some people get it only 30 questions, some get 100 questions like that. So, but better be prepared with more number of image based questions. That is the trend. 32-year-old comes to the emergency room after a street fight, and typically has a stab injury in the 6th intercostal space in the left midclavicular line. Then typically if you look at the surface markings of the pleura and the lung, if it is the 6th intercostal space, left midclavicular line will affect the lung, the stab will pass into. So that is the reason the left lung is the one which is affected. Now, whenever you cannot tolerate the sounds, that's called hyperacusis. What is the underlying problem? Typically it is the facial nerve which is abnormal, responsible for hyperacusis, because facial nerve is the one which supplies stapedius and that get affected. Upper border of the 10th rib in the right mid-axillary line, what does it injure? Typically it injures the liver. Liver is the structure which is there. A 65-year-old smoker complains of sore throat, throat pain, and there is an ulcer located in the area shown as A. What is the nerve supply of the tongue is a repeatedly asked 5 marks question in the MBBS first year exam. Those days we don't know why we are reading that. So you should know very well the innervation. Lingual nerve, which is the branch of the 5th cranial nerve, is the general sensory supply. Chorda tympani, which is the branch of the 7th cranial nerve, is the one special sensory which carries the taste. And you have the glossopharyngeal nerve, which is the one which is in the posterior aspect. And very posterior area, it is the internal laryngeal nerve, which is the branch of the 10th cranial nerve, which is the nerve supply. So, the nerve supply is very, very important topic. Similarly, among the tongue muscles, all muscles of the tongue motor supplies comes from the hypoglossal nerve. Whereas the palatoglossus is the only exception among the tongue muscles which is innervated not by the hypoglossal but by the 10th cranial nerve. The vagus is what you have to basically remember. A 26-year-old cricket player is brought to the emergency room complaining of back pain. X-ray shows a fractured 12th rib on the left side. Then what is the most likely lacerated in this broken rib? So once more, surface markings. 12th rib is the area where left kidney is located on the left side, and that is the reason there is an injury to the left kidney is what you need to remember. Now, typically what you are seeing here is a aldehyde dehydrogenase. So metronidazole, cefoperazone, grisofulvin, they all lead to disulfiram-like reaction, because disulfiram is also an inhibitor of aldehyde dehydrogenase. Whereas fomepizole is the one which inhibits the alcohol dehydrogenase. Fomepizole, that's what you need to remember. A farmer is brought to casualty unconscious with excessive sweating, lacrimation, salivation, constricted pupils, all excessive cholinergic activity. So what is the one of these plants extract is used, atropine, and what you are seeing is a atropine, Atropa belladonna is what you need to remember. So gingival hyperplasia is an adverse effect of phenytoin, one of the easiest question on the earth. Then from this plant, what is the active ingredient? Caffeine, correct. And caffeine increases cyclic AMP. Basically, it does not decrease but increase the cyclic AMP, you should remember. Now in the past, which acute drug reaction thalidomide, even a 11th class CBSE student also will answer. It's a NEET UG question, not even a PG question. Then what is the drag? 4 cycles are there, means tetracycline. If you know how to count 1, 2, 3, 4, that means LKG student also can answer this question, right? So what is the active principle of this plant? Obviously there is only one active principle, you know, is quinine. Quinine is obtained from cinchona bark. Now what is the active principle of this plant used in CHF? CHF only 3 drugs. D for digoxin, D for diuretics, D for vasodilators, D for death if you don't treat. So if there is typically digitalis, remember 2 things. Hypokalemia predisposes to digitalis toxicity, but digitalis toxicity as such leads to hyperkalemia. Digital toxicity, once it is toxic, it leads to hyperkalemia because it is an inhibitor, no, of the cell membrane sodium potassium ATPase pump. So it leads to hyperkalemia, but hypokalemia leads to digitalis toxicity. That's what you need to remember. Now what you are able to see here is a lipodystrophy. So typically lipodystrophy is the adverse effect of insulin, as all of you know. And what is this drug with A chain, B chain and all? Typically is an example of the structure of insulin. Then in the Graves' disease, how do you know that this is Grave? If you can see the upper part of the sclera, it is a Grave. Yes. So we use methylprednisolone, diltiazem, propranolol. They are all the part of the treatment of the Graves. Now typically what is the drug which is used in this given clinical condition? So it is showing filariasis. So in the filariasis we use albendazole, diethyl carbamazine, ivermectin, but not mebendazole. Now this given clinical condition is a tinea infection, ringworm. So we use grisofulvin, fluconazole, clotrimazole, etc., but not cotrimoxazole. Cotrimoxazole is trimethoprim sulfamethoxazole. Then typical route of administration is sublingual. So in sublingual we give nifedipine is the one which is being given. Now what is this? Transdermal patch. So we don't give nifedipine as transdermal. Then this is the intravenous route. I think too silly a question. So typically you don't use suspensions by intravenous because they lead to embolism. Now this is a spacer which is used in the asthma management. The main idea of using that is to avoid the development of oral candidiasis is a main objective. Yeah. It won't ease. Correct. They need to gargle the mouth, but when will you get oral candidiasis? If at all when we directly use, greater amount of that will remain in the mouth instead of going in. That is avoided by the spacer. So that way oh no. Complaints, in fact, people don't love to use spacer. They're more comfortable to use but some people who are not habituated to use that, like children, etc., old, very old people, we use the spacer. Complaints has nothing to do with this, but it's a tricky question that way. Right. There is no rhythm of respiration that need to be handled, but there are no studies to show that spacer's main purpose is not compliance. So it looks like that increases, but no. Now, because without spacer also people can inhale, and inhaling without spacer is more comfortable to use. What is more comfortable will increase compliance. But the purpose is, if you are directly using it, oral candidiasis is more common. That's the reason. Now, in the above figure, if B the drug which is being administered, and then A, if that is the one, then what is A? What is A? When the B is used, you are getting biphasic response. When the A is used, only monophasic response is there. So, if you look at prazosin is an alpha blocker, right? Whereas, if you use the adrenaline, so what are the receptors on which adrenaline is more active, noradrenaline is more active, and prazosin is more active? You need to go through that autonomic nervous system, receptor affinity of the various catecholamines is something that you need to once more review if you have done this question wrong. Now, normally what is the function of alpha receptors? Vasoconstriction. So, if you use prazosin, you are relieving the vasoconstriction. If you look at the beta receptors, they are there on the heart, the beta 1. So, when you happen to stimulate the beta 1, you will increase the heart rate. When the heart rate is increased, obviously both systolic and also it will affect both systolic and diastolic pressure. So, that is what I am saying. No. When it comes to alpha receptor, beta receptor activity, adrenaline once more within beta 1 and beta 2. Adrenaline and noradrenaline differ in their affinity. Most predominant action is beta activity if it is adrenaline. So, noradrenaline has got a more or less an equal activity on both alpha beta. So, similarly dopamine also differs. Dopamine has more effect on the mesenteric and renal vasculature. So, that way, that is what I am saying. Autonomic nervous system pharmacology, you need to review on the various receptors and what is the effect of different catecholamines and what is the alpha 1 more than alpha 2 more than beta 1 more than beta 2, another beta 1 more than alpha 1 more than beta 2, like that. So, that particular order you need to remember and master. Now, what is this graph basically showing? There are two kinds of drugs. One which affect efficacy, other which affect potency. So, what is the meaning of the potency? For a given effect, if that can be achieved with a smaller dosage, you call more potency. For the same dosage, if a greater effect can be achieved, then such a thing is called more efficacious. So, typically, it is a non-competitive antagonism where the maximal response becomes suppressed. Competitive versus non-competitive, if you compare, the effect of a non-competitive inhibitor compared to that of the competitive inhibitor is, it mainly affects the efficacy, not the potency. So, that is a point of interest for you to recognize. That is a non-competitive inhibitor. Now, the one which is acting on the proximal tubule obviously is the carbonic anhydrase inhibitor. A 65-year-old who is a chronic alcoholic is being brought with a complaint of massive hematemesis, and he succumbed because of the massive blood loss, and on autopsy the picture is being shown. What you are seeing is esophageal varices. They are typically esophageal varices. The next question is, what leads to development of esophageal varices? Cirrhosis, portal hypertension, Budd-Chiari syndrome, any of them can cause but not myocardial infarction. Now, a 32-year-old peripheral smear is showing hypersegmented neutrophils, which are typically seen in the case of the megaloblastic anemia. So, in the next question, how do you want to evaluate it? Serum vitamin B12. And what is the cell which is being shown? Hypersegmented neutrophil. Then what is the type of? Giant cells are divided into 3-4 types. Looking at the micrograph, you should recognize. So, typically it is a Langerhans type of giant cell. And in the next question, what is being shown? The giant cell is called a foreign body type of giant cell. And in the next question, the type of giant cell being shown is called Touton kind of a giant cell. Now, in which condition you see the two-tone type of giant cell in the case of the xanthal asthma. Huh? Correct. And in into this lipid, because of the, I mean, it's the inflammatory cells will prevent the foreign body from spreading across the inflammation. Absolutely. Basically, formation of a giant cell and a granuloma is a defensive mechanism of our body naturally to prevent the spread of the histopathology. Yes. Basically, these three pictures you put side by side. There is a description given for each of them. Actually, just review that. Now, we have a foreign body type of granuloma, which is typically seen in foreign body. Then you have a Langerhans type of giant cell, which is seen in tuberculosis. 70-year-old has got a rectal bleeding, and this lesion which you are seeing is colorectal and ulcerative growth. That's the reason, in view of the age, we consider adenocarcinoma. In a 40-year-old non-vegetarian, so typically it is a hydrated cyst, which is commonly seen in the liver. Obviously, no. Hydrated Echinococcus granulosus and white is not amoebic, you mean to say, but in view of the appearance of it and the history being given and the scolex being shown, non-veg is correct, but the scolex is a dominating factor that should make you to choose what you rightly have chosen. Then a 50-year-old chronic alcoholic, hypochondriac pain, liver biopsy shows. Obviously, this is a very silly and easy question on the planet Earth. Oh no, focal nodular hyperplasia, you meant to say because of this clustering of the fibrotic appearance. You should not confuse, that is what examiner wants. No. Focal nodular hyperplasia, you need to see the histopathology. See, the point is, entrance exam, after you pass, you join MD pathology also, you are full-time pathologist also, the doubts remain, right? But what for getting into MD exam expects you is, generally what is your, have you gone through the Robbins pathology, common pictures given or not is what it will check. So, that's the point. Now, what is this lesion, 40-year-old with a bleeding per rectum? So, he is a relatively younger guy and there is a confluent lesion which is from the rectum involving the entire intestine, that makes it to become ulcerative colitis. Skip lesions. Easy way to say is Crohn's skips to reach the mouth. You also have aphthous ulcers in the Crohn's. Now identify the lesion, 50-year-old complaining of bleeding per rectum. So once more this is a case of hereditary adenomatous polyposis which has got a 100% incidence if you don't operate. So prophylactic colectomy is also done in case of PAP. Now what is this typical marked cell? So what you are seeing is the spherocyte. RBC is spherical without any central halo, that makes it a spherocyte. Now what is this parasite with the ring forms? Classically is a question of malaria. And what is this hemoparasite classically identified as? Eukaryaria benkorefti. Then what is this lung condition? I think easiest question on the earth. If you can't identify a sponge of emphysema. So what was your answer? This is classical lung with dilatation of all the barrel, not in the radiograph. In the radiograph, because the hyperinflated lungs. Point of how to identify functional emphysema in this case is, you have got multiple dilatation of the various bronchi and the alveolar spaces. So there is no bronchiectasis. That would have been more confusing. But in this case it is no. Bullae will be there. No, emphysematous bullae. So they lead to development of this kind of appearance. Sometimes patients will be happily saying tata, goodbye, and while they are taking out, suddenly one bulla ruptures and they go into spontaneous pneumothorax and collapse in the ward also. I can never forget. Veera Reddy was the patient with a sarpanch who had a emphysematous bullae that got ruptured and collapsed and passed away. And he was otherwise a very nice man, every day talking about his life as a local politician. So he used to write a nice diary also. Today doctor has treated me, spoken to me and all that. So after he passed away, we have gone through all the diary. Luckily he wrote good things about us, you know. So multiple bullae. So this is basically a vaccine viral carrier. Actually our preventive medicine exam, MCQ setter has a fantasy for images. Your own wife's image you don't remember. So where will you remember one of the oldest, actual exam also they don't give like this. So they will inform him that next time onwards let not scientist images come. That's nonsense. That's like you are going for a 10th class general knowledge exam. So he is actually Hippocrates. He can be your grandfather also. You can say, no, this is not Hippocrates, it's my grandfather. So this guy is Jon Snow. And this guy is Walter Reed, who discovered the transmission of yellow fever. And this guy is Ronald Ross. In Hyderabad only, on the Hussain Sagar, he discovered mosquito bite is responsible for malaria. Now this is a good question. Identify the instrument. So fundamentally it is a Carter thermometer and it is a alcohol thermometer which is used to measure the low velocity of the air circulation. This is an excellent question. This is a repeatedly asked question in and what is inclined, what is hanging, all these things, favorite question of the examiner. In Park textbook you have got 3 images of the characteristics differentiating. Whether you like, you don't like, you cry that do I need to remember this also to get into MD, but you have to remember there is no way. So it is Anopheles larvae lie parallel to the water. And typically, which one? Culex feeds below the water surface. Yeah. And it has got a broader head compared with of the Anopheles. There is a list of differences actually. Now this is a typical tiger. A tiger mosquito is Aedes aegypti because that stripes that it is having. These bugs are the big bugs. So typically this is an example of a head louse. It causes the head lice infection in the school going children. Now this organism is a scrub typhus causative trombiculoid mite. Then in this condition, what is this rash? So classically it is a smallpox rash, it is uniformal, centrifugal in nature. But it can be herpes also, look and feel. But the point is, by the appearance in the trunk and all that. Because smallpox eradicated, you marked chicken pox. Okay. But NEET PG is not eradicated. So it will give those things which happened during the Egyptian era also. Possibility is there, but truncal distribution of the rash, etc., is the one that should make you to think about it, right? So it's a normal distribution where mean is equal to median is equal to mode. Now, typically, where do you see this finding? In lead poisoning, you find the Burtonian line, which is the one which gives you an indication of the poisoning. Then what is this symbol? So classically it is HIV or AIDS. The red ribbon is the international this thing. Then what does this basically signify? So National Leprosy Eradication Program, the symbol typically states that leprosy can be cured, leprosy patient can be useful member of the society, and we should remove the stigma of leprosy. That's what the symbol signifies. Now this is the typical logo of UNICEF, which is headquartered in New York. And already vector is sitting on the top of it. So if you know NVBCP mein V is vector, you can be able to answer. Then what is this? A good question. Identify what is this symbol. So typically it is the pesticide toxicity labels which help in categorization of the pesticides based on their toxicity levels. So this is the typical red cross. I think this is the cheapest question on the entire exam.